Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, January 11th, 2022, and I want to thank you for joining our Facebook Live. As always, this is where we take your questions directly. You can put your questions on COVID directly into the box below or use the hashtag AskDrArwady on either Facebook or Twitter. Let's go ahead and dive right in. We'll start with our dashboard. chi.gov/COVID-. And if you take a look at this, there are some signs of promise in terms of the Omicron surge here. I'm guessing people will have questions about that, and we will take it. I want to be very clear that we need to see signs of progress for a number of days here. There's been a lot of disruption of testing, with the surge. The number of cases that has been coming in has been really stretching some of the computer systems, honestly, at the state level, et cetera. And so I continue to see signs of progress here, but it is too soon to be clearly saying that we're turning around. However, let us celebrate good news where we see it, which is that we are averaging 4,793 cases a day right now, which is down 8% from last week. Hospitalizations up 187 a day right now, up 37% from the prior week. That's the delay, right? Like, we would expect to see hospitalizations continuing to increase. And I just want to note, because we did get some questions, up at the top here, we had a note about dashboard data updates being delayed for hospitalizations only. That is now up to date again. So we'll get that note down. And I just want you to know that thanks to some additional work from the state over the weekend, this hospitalizations data and all the details within it, you can go in and look at cases and ages, is up to date. Deaths are currently averaging 17 a day, also up a day. That's also lagging, not unexpected. Vaccinations are up, which is good to see, 11,500 a day. Testing at about 28,000 daily. And then our positivity here, again, down just a little bit, 18.9%, down from 21%. I think for time, I won't go further into too many details here, but let me just show you, because a lot of you have been wondering what's happening with hospitalizations, how you do that. You can click here. Here's what the hospitalizations look like. If you want to see what's happening with age, for example, there, and you want to, make this over the last, I don't know, like month or something, you can look and see that right now, in blue here, this is at the bottom, those are our 0 to 17-year-olds. We're averaging 2 hospitalizations for every 100,000 children for COVID-19 right now, whereas for those over 80, we're averaging 36 per 100,000 being admitted to the hospital newly with COVID every day. So feel free to continue. You can look by race, ethnicity, gender, et cetera. You can look at vaccination rates by zip code, by cases. We are actually working on getting booster data in here and continuing to, in the upper part here, where we were linking people to the hospital capacity dashboard, just while there was a little delay in data coming in. I want you to know we knew what was happening behind the scenes. It was just working on the technical issues there of getting it into the dashboard. And so we were pointing people to our hospital capacity dashboard. Those of you who follow along know that up here under latest data is where we put a lot of other things that are not necessarily in the dashboard. But for example, we were updating what's happening with variants. I think that update just went on yesterday. What's happening with all of these things, but specifically, this is the same link. It's the hospital capacity. This gets updated every single day separately from the dashboard. This is about how many people right now are in Chicago hospitals with COVID-19. Acute non-ICU beds, you can see 1,563, 18% of acute non-ICU beds are available, which is okay, though hospitals are very stretched. Similarly, our ICU capacity, there are currently 304 patients in Chicago hospitals with COVID, and about 10% of our ICU beds available. Again, stretched. Certainly there are places downstate that have 1% available, and we're concerned because we are a referral site also, obviously, for the region in terms of hospitalizations. And then a number of you, like Becca Wood on Facebook, was asking, are there still people being hospitalized with Omicron who are needing vents, et cetera? So, this is where you can also see that. These are people right now in Chicago hospitals on a ventilator with COVID. There are 168 of them. We have plenty of ventilator capacity, but that is up similar to our peak last winter, still well below the initial peak. Again, the reason that the ICU and ventilator data, although high, is not what we were seeing in line with prior hospitalizations. And then more importantly, the hospitalization data is not what we're seeing in line with other with other surges in terms of cases. That is all because of vaccine predominantly. So let me show you a couple more slides, and then if you have additional questions, including about hospitalization data, I am very happy to take them because it's one of the main things we do. So a lot of you are asking sort of what's happening around the world, and let me just get into the slideshow here and just show you some of this. Okay, so first of all, nationally, the places in the darkest purple here are where we're averaging more than 65 cases per 100,000 people in the past week. Really, within this, you're seeing in Europe, that's where Omicron surging just a tiny bit before us. Also some signs of some flattening there. Population really different in terms of underlying conditions, age, prior vaccination, previous exposure to COVID, to what we had seen in South Africa. But nevertheless, some early signs of promise here. I continue to feel optimistic that 90% chance we'll see this peak in January. All along, I've been saying feel about 90% that we'll probably see Omicron's peak in January here in Chicago. And then I've been saying about 50% sure, we'd see that peak in the first half of January. And, today is January 11th. So as we're coming toward that middle, starting to see some early signs of possible improvement, but still at very high levels. We have seen, you see the numbers here, 297 million diagnosed cases around the world, more than 5.4 million deaths. Look at this, we're getting close to 10 billion vaccinations administered around the world, which is really remarkable. And 60% of the world's population now have been vaccinated. Where we look at the U.S., I just wanted you to kind of see the map. We certainly remain in purple here in terms of those high daily case rates, but I just wanted to help remind you kind of national context. And because Omicron is moving so quickly, number one, the entire state is on the travel advisory again in terms of it being high risk, and we'll share some additional details of that. We have a press conference at 1 o'clock today, but the whole country is in a very large surge because of Omicron. Nationally, we're averaging about 222 cases per 100,000 per day right now. Illinois is about 249 cases per 100,000 people right now. Chicago down just a touch to 177 cases per 100,000 per day. So just things are moving very quickly here, depending when you grab the data. Even day to day, we're seeing a lot of change, which is why it's important that we're updating that dashboard, every day like we are. So what is different with Omicron? I think folks largely understand this, but I thought it was worth just showing you this picture because this is just out of the New York Times, but it's reflecting what we are seeing in Chicago is also what we are seeing nationally. And the big difference here is that, do you see the cases here, this red line just shooting up dramatically? However, that red line is not turning into as dramatic yet of an increase in hospitalizations or in deaths. Yes, these are lagging indicators, but still, without vaccine, without people protecting themselves, with this kind of a surge, prior to vaccination, we would have had absolutely no option except to completely shut everything down. Probably would have overwhelmed the hospital system, honestly. So this is what we're seeing. And just to give you a sense, every state is seeing this. So I pulled this What you're seeing, again, not the details, but the red is what's happening with cases in Rhode Island and New York and New Jersey and Florida and DC and Connecticut and Arkansas. Like, it doesn't matter where you're looking. You're seeing this huge spike in cases in red, and then you are seeing very real and very stressful to the hospital system increases in yellow, and then you're seeing deaths here in gray. And so the pattern that you all are feeling, where everybody knows somebody who has recently had COVID, but especially if they're vaccinated and boosted, they're less likely to be getting seriously ill, is true. But the number of cases are so high that there is certainly still concern for the healthcare system. This is part of why we have that temporary vaccination requirement in place for the highest risk settings. So the case rate, highest that we've seen, certainly. We had a day 3 days after Christmas where we had more than 7,800 cases diagnosed, by far the most. Positivity, again, possibly ticking down. I need to see a few more days knowing that all the data is coming in, that there's not reporting delays, and making sure that things are that we're actually seeing a change there before we can fully call it. But certainly, I prefer seeing that than continued major increase, of course. Here's the hospitalization data, again, across the system in Chicago today. This is our capacity. We continue to talk a lot to the hospitals. Please give a shout out to any healthcare worker you know right now. They are all working extremely hard and doing everything they can to make sure that we can maintain high standards of care. As I pointed out, hospitalizations do remain low among children 0 to 17. Child hospitalizations have increased. That is particularly among unvaccinated children. We had a question in already. I saw one about our teenagers, are you seeing teenagers being admitted? We are. And we have shared publicly, you can look at this if you want to do more detail online. Unvaccinated teenagers, 12 to 17-year-olds, are accounting for a lot of where there has been an increase in hospitalizations, but thankfully those numbers remain very low. But look at those rates. In that gray is people over 80, and that pink is people over 70. The green is people over 60, and most of that, again, largely, in the younger people, it's virtually all people who are unvaccinated. In the older people, it's still the great majority are unvaccinated, but we do see, more breakthrough, even hospitalizations in people who are older with serious underlying conditions. I already shared this. This is just from the dashboard. In terms of our community transmission and risk matrix, we remain in the very high for cases and test positivity. And we've talked a little bit about, with the changes in testing and at-home tests, how those numbers in some ways are less important than what we're seeing in hospital capacity, and we can talk about that if you have questions. But those are decreasing, at least tentatively. Our hospital beds with COVID patients continue to increase, and our ICU bed with COVID patients continue to increase, remains in that high transmission. The messaging remains the same, but vaxxing up and boosting up remains the most critical thing. We did hit 77% of not just 12 plus Chicagoans, which is what we had been aiming for with Protect Chicago 77, but all eligible Chicagoans over the age of 5, 77% have now had at least their first dose of vaccine. Important milestone, still a ways to go. Where we break this down by vaccination rates, you can see that people in their 50s here are still the most likely to be vaccinated. I'm especially concerned about those people over 70 and 80 who are still not vaccinated. And then you see pretty good progress there in the kids across the city level. We were certainly lots of focus on school and CPS data, so I did just want to share this with everybody. Across the U.S., where we're looking at adolescents, 12 to 17-year-olds, about 64% have had a first dose. City of Chicago overall, 72% have. And then behind the scenes, my team does some matching against the CPS enrollment data and then iCare, which is our vaccination records. And so we can see what's happening in schools by grade, different languages to help inform the outreach. And so it is likely that there are some mismatches there. If a child is registered in school with a slightly different last name, for example, then they might be in the registry. But this is, generally speaking, we would, the great majority of the match should be there. And so more room to go on 12 to 17-year-olds. Where you look at 5 to 11-year-olds, I'm very pleased. In the U.S. overall, less than a quarter have had a first dose. We're well above that, both for 5 to 11-year-olds in CPS and non-CPS, but boy, is there a long way to go there. I wanted to highlight, I got a question in from Derek Golan, wondering about what's happening for distributing at-home tests, masks, et cetera. So we did today and yesterday. This week we are distributing an additional 1.7 million KN95 masks. They're going out, they went yesterday to about half of the aldermen, today to the other half of the aldermen, and then Wednesday through Friday we've got more than 100 community-based organizations. These are a one-time distribution. They're not meant to be, forever, but in terms of kind of getting us through the surge and making sure, especially people for whom 50 cents or $1 is a lot to try to get a higher quality mask, we felt that was important. We're also distributing, on the left there, you see this high-level guidance about what to know right now if you are sick, because just as guidance has been changing, I felt like it was important to help people know how to find a test, some language about masks, et cetera. And still, for the most important thing, as I've said over and over again, is that everybody is wearing a mask, that it fits well. For extra protection right now, you can wear a surgical mask underneath a cloth mask, and then the KN95 masks do offer the most protection if you're wearing it properly over the mouth and nose and keeping it on. So that's been a big work this week. Also, a number of you were asking questions about Shield. So Shield, for those who don't know, is a saliva-based COVID test. It is a PCR test. Shield is about laboratory capacity. It's not about staffing for collecting. And I just wanted to be clear, CDPH already works with Shield. We have a contract. We do various work. We work with some of the non-CPS schools. We work with community sites. We have been working to link additional sites with Shield to expand their operations. So just to give you a sense, starting tomorrow, the federal courthouse downtown is going to be opening to the public to do that Shield testing. CDPH is funding that, and where some of this capacity is in place, working to have that be open to the public. That's not going to be the only place. That's just the one that's opening tomorrow. And just to give you a sense, chi.gov/COVID test remains the best place to get Chicago-specific information, or you could just call our same number, and they'll stay on the line with you, helping you figure out how and where to get a test. We are also working on further expanding community-based testing. So again, it's not just about can I stand up testing everywhere, it's making sure that testing is in the places where it's most important for public health, and especially anything that decompresses emergency departments. We still have a lot of people coming to emergency departments to try to get a COVID test, and that just adds additional stress to the already stressed system. So the other thing is that we want to have testing in areas where there's a lot of high-risk people, where hospitalizations are the highest, and making sure that a positive test, especially a positive rapid test, links people to care, make sure they can get medications as those are becoming more available to help keep high-risk people out of the hospital. So we've begun some additional testing work at the Illinois Medical District. So if somebody's showing up to a hospital, all they really need is a test. I don't want them anywhere near that hospital. I want to be able to say, walk a block that way, there's a testing site available for you. And then similarly, Daly College, a site that we know to be in a high need area and can be connected. There are not a lot of rapid tests available at all, but the good news is that they are just starting to flow from the federal government. They're starting at federally qualified health centers. So last week, more than 20,000 already came through to federally qualified health centers. Again, you want rapid testing available where you have an intervention. And the intervention is also making sure that as more and more comes in, those same sites can get people on the medications that if they do get infected and they're high risk, can help keep them out of the hospital. Also good news, our weekend family vaccination clinics in partnership with city colleges have been going like gangbusters. you might recall when we initially set this up, we had planned, we've been at all the city colleges twice, each Saturday and Sunday over the last, since vaccine became available for the younger kids. And I've been really pleased. Good numbers at those. We've seen a nice mix, like at Truman over the weekend. We had almost 30% of the folks getting vaccinated there were adults getting their first and second doses, which is like my favorite thing to see, honestly, in terms of risk. We had about another third or so of pediatrics getting their first and second doses, kids, and then we had about a third getting their boosters. So we've been pleased with that, and given surge, popularity, interest, we are going to just do another whole round of that. So Saturdays and Sundays here going forward, we will continue to offer those and keep working to get people vaccinated. That is the most important thing. Final reminder, a positive test is positive, no matter what kind of test or where it is done. There is no need to repeat tests. It doesn't matter to me if that is an at-home test, if that is a PCR test, if that is a test done at a school, if that is a test done in a clinic. If there is a positive test right now in the city of Chicago, that test is positive. We treat it as positive, and you do not need, please, especially when testing resources are harder to get, to go out and try to repeat that. Treat it as positive for the general public. If you get a positive test, you need to isolate, stay home for 5 days. And then if you're still not feeling better at 5 days, keep staying home until you feel better. And we can answer more questions about that. It's also really important in those the first 5 days, you should be isolating as much as possible. The second 5 days, if you're feeling better, also try to be avoiding higher risk people settings. Make sure you're wearing your mask. But this is just because Omicron moves so much faster that we really are seeing people, especially where they're vaccinated and boosted, very quickly moving through the whole phase and not spreading virus definitely after 7 days, and really in the great majority of cases, not after 5 days. And that's why CDC made that change. As always, this is your number to call. If you need a vaccine, you need a booster, you need help, you need a question, you're even testing, we're supporting on this right now. And please do call us if you have questions. All right, let's take some of your direct questions. I know that was a lot of data, but I was trying to hit on some of the questions that we were getting from all of you. Okay. Lisa Baldavenaria on Facebook. What is a common first symptom of COVID? Surely it varies, but I have friends who noticed a sore throat first and decided to get tested. So wondering if sore throat is a common indicator. Yeah, especially in people who were seeing these more mild breakthrough infections. We are definitely seeing sore throat be a predictor in that group. So what I say again to everybody is that in this surge right now, you should presume if you are having cold, flu, new not feeling well symptoms, that is COVID until proven otherwise, okay? So even if it's a sore throat, no matter what it is, I've told my own staff, this is what I do myself. If you're feeling, remember my first message from the very beginning, if you are sick, even a little bit sick, stay home. More true than ever right now, because sick, even a little bit sick, until proven otherwise with a test, is COVID. That's how we treat it. That's how you should treat it. And so this is where, as testing capacity continues to build, et cetera, yes, that definitely can be. If you've got an at-home test and you can take it and it's positive, that's COVID. Yes, good question. Okay. So Maribel F. on Facebook says, my 93-year-old mom cannot leave the home to get a booster shot. Can anyone come to her home to give a shot? Yes. So our at-home program for vaccination continues to also go like gangbusters. So we are definitely the only large city, and honestly, the only city I'm aware of that has had this extended, continued at-home, Protect Chicago at-home program. We've moved a lot of the resources from sort of popping up a clinic here and there that had pretty variable uptake to making sure 7 days a week into the evening we are setting up appointments for people where we bring vaccines to their home. And that includes our top priority are first and second vaccine doses, but yes, also boosters. We can give Pfizer and J&J, but really the focus is on Pfizer at the moment. And if remember, you can get any of the boosters that are available. And we can, if you call 312-746-4835, especially if you're saying you're 93 and it's hard to leave home, we will set you up with a booster appointment. I want folks to know, we are doing 1,200, 1,300 of these sort of mini home-based clinics each week. It's a lot. And so it may be a week or two, okay, depending where you live and the availability. We also had staff ourselves. Obviously, we're extra careful for those staff that if they even have the slightest bit that could be COVID, they're vaccinated, they're boosted, but we would hold them off. And so we had a little bit of decreased capacity ourselves, as everybody has across the country, across the city. So yes, she can have this. Some more boosters. Carolyn from Facebook. If you had the J&J, when can you take the booster? Okay, if you had the J&J, you are who I am most interested in having you get a booster. You can get a booster 2 months after getting your Johnson & Johnson shot. Let's talk about timing a second, because that's another thing. I know it just feels like the whole world is changing, but CDC and FDA looked at data and said for Pfizer and Moderna, you can get a booster 5 months after, not 6 months. You can get it at 5 months. There's vaccine available. Again, this is just around making sure that we're doing, in a surge, making sure we build that antibody level back up. But I'm less worried about that. The J&J, 2 months has been the recommendation all along. It remains the recommendation. And for people who got J&J, I would recommend for your booster that you either get a Pfizer or a Moderna. When we looked at the studies, the increase in antibodies was better with a second dose of either Pfizer or Moderna. I don't care between those, and if you started with Pfizer or Moderna, I don't care which one you boost with. No major changes there. But for J&J especially, please get a booster, and I would recommend Pfizer or Moderna. And then here's just one more booster while we're at it. Sheila asks from Facebook, how soon after getting COVID can you get the booster shot? Somebody got 2 Pfizer vaccines last April and tested positive December 27th. Should she get a negative test just to be sure? Okay, so a couple questions there, but these are all good. So you don't need to wait after having COVID to get a booster. You should wait at least the 10 days, okay, during the time that you could be infectious. So if your test was positive December 27th, you got to wait at least 5. I would just wait the 10 days, okay, which you're now at. You can get a booster at that point. Now, in terms of the people who are highest need for a booster would be people who it's been a really long time since they had a vaccine, they haven't previously had COVID. You've had some protection there. Certainly, if you've had a recent COVID infection, you've had your antibodies go up. But my recommendation to my staff, to my family, to everybody is, particularly with this surge right now, I would still recommend getting the booster. To your second question, should she get a negative test just to be sure? So again, this is someone who got Pfizer back in April, very recently, December 27th, had a positive test. And I think you're asking, does she need a negative test before she should get a booster? No. And again, this wasn't exactly your question, but let me remind people again about tests. So if you get a PCR test, it's very, very sensitive, meaning it will pick up COVID, even dead COVID in your nose, COVID that you're not spreading. PCR tests can stay positive for a very, very long time. It does not mean that you are infectious, spreading, contagious with COVID. And this is that's not a change. That's something we've seen forever. It's why there is not a recommendation to get a negative PCR test before coming back to work, before coming back, because lots and lots of studies have shown that the PCR test can stay positive, but you can't, if you actually take that exact same sample, you can't grow that COVID. It doesn't grow in culture, it can't spread, and it just has to do with how sensitive the test is. Okay. And yeah, and so I kind of just answered this, but we've got Take a Joyful Jump on Twitter. I like your name. It says a friend keeps testing positive after 14 days quarantine and no symptoms, but job requires a negative test before she can get back to work. We know tests can give positive results for months. What should she do? So there's a few things. Certainly you could get a letter, from your healthcare provider saying you're recovered. There is also language on our website that clearly states that we do not recommend that workplaces require a negative test. So thank you for that flag. If that's happening some more, we can make sure that that's elevated and easy to find on the website, but I know that that is available. And I know, again, there's just a lot of concern. But 14 days later, you are fine. You do not need to show a negative test. Okay. All right, we've got wastewater questions. How about that? So Amy Hand on Facebook and then Lisbeth Lynn on Twitter is saying, Amy says, is the city testing wastewater for COVID to have another measure of cases and spread? I read that Boston does so. Lisbeth Lynn from Twitter goes a little further. She says, how can I find wastewater data for Chicago? I see some general information about wastewater testing on the dashboard, but I don't see the data. Okay, great. So for both of you and for everybody, let's talk a little bit about wastewater surveillance for COVID. So if you've never heard of wastewater surveillance, it basically means not just for COVID, but at a population level, if you want to understand what is happening in a population in a way that does not require individuals to go and get a test, you can check sewage, their poop. And we've talked about this a little bit, from time to time here, but it's a good moment to remind people. So if you get COVID, we can find that you had COVID by testing your stool, your poop. It is not infectious. It is not spreading COVID dramatically through the sewer system. I don't want you thinking that. It's like this thing with, the PC. You can test positive for a long time, but it's not spreading. But the nice thing is that if you sort of play this out, this has been one of the things that, frankly, CDPH wanted to have some systems in place for doing some population level monitoring of things well before COVID. We had been talking, for example, and looking for funding, frankly, to be able to follow things like what level of opioids are we seeing at different neighborhood levels? What levels of Narcan, which is the medication that's used to reverse an opioid overdose, to save somebody's life. What level of that are we seeing? It's a way to understand quantitatively where are you seeing more problems with certain kinds of problems. But with COVID, where we've gotten additional funding to build this, yes. So the Walder Foundation, I really want to give a shout out here in the Chicago area, very early on asked us what are some of the things that they could help support academic institutions around financially, things that we needed sort of from a public health standpoint that would help us better understand what was happening with the spread of COVID in Chicago. Huge thanks, very early on, they worked with both us and Cook County to look at suggestions that our academic partners had about things to study and things to follow up on. And then subsequently, there has been quite a bit of additional federal funding. And so just to kind of play out for you what this looks like, at different levels, number one, if you are taking a sample at the sewage treatment plant, the water treatment plant, that's just giving you a general sort of for the whole city. But this can be quantitative. So high, low, how are we doing as a city? There's a way very broadly to look at that. But a lot of this data is newer. So it's not like we're following, in the details yet. But you also could potentially, where sort of sewer systems come together, you could do some sampling across, a number of neighborhoods. What is happening in this neighborhood? And then also, in some of our highest risk settings, we've been working again with partners to think about things like at O'Hare Airport, the ability to see where we've got people coming in from all over the world. Are we seeing, what are we seeing in terms of COVID or even, other diseases? There is the ability to do that same sequencing and look at variants too, right? Where are we seeing variants in this potentially? And then even more specifically, the Cook County Jail has just been doing a really, really good job with everything related to COVID. They have a lot of folks who are coming into the jail right now who are positive for COVID, and they've been working to really increase the ability to make sure those folks are isolated and get the care they need, et cetera, without to not have further spread within the jail, and they've really been very good and aggressive on this. But one of the things that we've been working with them on is if, for example, you're taking a sample, not just at a neighborhood level, but within a big setting like an airport or like a jail, if you're taking a sample from the different wings, at a time where you shouldn't be seeing any COVID in those wings, right? If these are people who are past their isolation, they're getting tested. If you even see that there is COVID, you can very quickly go and do COVID testing and figure out who's positive, because you don't know who is positive in doing any of this. Act on that and make sure that you can use it as another tool to keep this safe. So absolutely, we are part of this. The Discovery Partners Institute at UIC is kind of the lead. But all of the, with CDPH, but all of the, lots and lots of academic partners have been pieces of this. And then we're part of a much larger national conversation with, yes, Boston, but also all over the country, lots of work to do this. Why don't we have specific data posted is because this work is still working on figuring out sort of what is of significance to public health, what is the baseline, where do we expect, and so we are using it, as I said. There's been some work to sort of think about at O'Hare, what does that look like, or in the jail, some of these settings, and there has been data being collected, but it's all sort of beta still, if you know what I mean. It's not at a point, and this is at the direction of our academic partners, et cetera. It is a surveillance system. And when we say surveillance in public health, just to be clear, surveillance, all that means is data collection. It's the formal term for collecting data, especially sort of at a population level in a way that is not individualized. And so, in the same way, us following how many rapid COVID tests are being purchased in, the city, the state, the whatever, you get a sense of what might be happening with COVID in a very broad way. These sorts of systems also help you understand what's in a broad way. So I hope that gives you a sense of some of what is happening here. Obviously, really important to do some more of this. All right. Once again, Arani Pereira on Facebook. I just want to say this again because I see a number of people asking. How soon can you get a booster after testing positive for COVID? You can get a booster 10 days after testing positive for COVID, assuming you're feeling better. Brandy Emberton on Facebook. We got some mask questions here. I just joined. Sorry if I missed. Nope, you're good. Where can I find the list of FDA and CDC approved KN95 masks? Okay, so KN95 masks are FDA and well, FDA, but actually, you know what? I said that it's FDA. I actually meant that it was NIOSH. We'll make sure there's a link in terms of where you can find it on our website. It gets a little bit confusing because there's the Food and Drug Administration, and they're looking at the details. There's NIOSH, which is the National Institute of Occupational Safety and Health. So I can imagine where you might be having an issue finding that. I think there is already a link, but if not, we will make sure there is one on chai.gov, / COVID to make sure that is there. But if you go to the FDA or the CDC, I know they also have the links everywhere to this one list. I just, off the top of my head, I don't know what the URL is. But we will get it for you. And actually, that would be a good post on social too. So if you don't follow us on Facebook or Twitter, or I don't know, any of these other social media platforms, I'm going to ask the team to actually probably put that together into something that we can put out today, just because other people may have that same question. Maggie K9 on Facebook, re-mask upgrades. Can you talk about care and reuse of KFN94s, N95s, KN95s? Will using a cloth mask over or under it help preserve it? And Maggie says, I'm not a fan of disposable masks. With shortages, I don't want to use more than I need. Thank you, Maggie. Okay, so first of all, there actually are protocols, and for those who may not be quite as sort of into the numbers of the masks, N95s are all 94, 95. What that means is it filters out 94 to 95% of particles. They all work great for COVID. The difference actually has to do with how they are getting approved. To that first question about where are these getting listed, there are certain, the N95s are primarily, they're really meant for medical settings in that you have to do fit testing. And there's a type of N95 you can buy at the hardware store. You can wear those if you want, no problem. Those are sort of more, those are really not very comfortable. If you think back to the beginning of the pandemic when there were lots of pictures, not in Chicago, but like around the country, of health workers with like these like lines on their face from their masks, that was really because at the surge, not everybody had N95s in stock like we did here. And there was more need to use those really not very comfortable hardware store more type masks. So healthcare system has what they need now for the N95s. But the numbers on them just have to do with sort of who is approving them and certifying, et cetera. In terms of reusing them, so first of all, will using a cloth mask over it or under it help preserve it? Do not, please, wear a cloth mask under any K94, 95, any of that. Why? Because the whole point of the KN94, the whole point of these is that the seal around your nose and mouth is a lot tighter. And this is where that trade-off comes, right? Where, you know, I am not, just so you know what I'm doing, I am not wearing a KN95 in my day-to-day life all the time. I continue to wear, you know, surgical masks are they're comfortable for me. I like them. They're what I'm used to. I've been wearing them forever. I am layering a cloth mask over that because for me, this is something I can keep on sort of indefinitely without a problem. If though I am in a setting that feels not so comfortable, certainly if I had to travel through an airport or I were in a crowd, or I am trying to not do too much unnecessary being in places that don't have mitigations in place. But that's the setting. I keep one in my pocket and I will put on, you know, I do have a few of the KN95s here. To the point of reusing them, there are protocols actually for being able to reuse all of these masks, even in medical settings. So if you're interested in the details, you know, even when I was in, when I used to work full-time in hospitals, right? Full-time in hospitals, these masks are not new with COVID. We've had them, we use them for tuberculosis, et cetera. And you can like use the mask, and then if you store it in a bag and, you know, wait a couple of days, you can use it again. I would say to you that in terms of sort of, you will sometimes see some of these masks, you know, they might say 4-hour, 8-hour, 12-hour, you know. The idea of that is primarily around, you know, that's just a long time to sort of have a mask on your face in terms of comfort levels, et cetera. It is not that the protection goes down in any way, okay? But if you've been using that in a higher risk setting, you may have gotten more germs, right, onto the outside of the mask, not just COVID, but other germs. And so if you're really wanting to circulate those, if you want to wear a cloth mask over an N95, that's fine if you want, but not under. I don't think it really adds protection, but you're right that it would probably help a little bit if you really wanted to in terms of just having less sort of germs of all types kind of get onto the surface of that mask. But I do personally reuse my KN95 you know, day after day. I keep it in a little plastic bag, just so you know, like in my pocket, in my bag. I want to try to keep it, you know, clean. You know, the cloth masks you can throw in the washing machine. That's one of the reasons we like them, right? You can continue to use them. But in the same way, if, you know, if I see, you know, if you actually look at for these, how long the, you know, if this is looking dirty, if it's on and off, of course I throw it away and I put on a new one. The KN95 is in the same way. It's looking dirty, like throw it away. You know, these are not, I don't want you thinking that you should wear one mask from here to eternity. This is sort of, especially while we're in the surge, especially in a higher risk setting, but these are just not as comfortable for me either. And again, the most important, that's just me, maybe you've got one that's really comfortable. The most important thing, everybody's got one on. The most important thing these are doing is source control, keeping your germs to yourself. As you upgrade your mask, you are upgrading the protection of yourself, but still, mostly, you need everybody around you to also have one on. Okay. Oh my goodness. So you guys have interesting questions sometimes. So first of all, I'm just going to read a couple of these, and I'm just going to go ahead and take them. So Liz Thompson on Twitter is saying, please explain some studies behind KN95 use in children as effective, that it works in a school setting. Schools in multiple other states and countries are operating without masks and are fine. At what point will you stop recommending this? So I want you to understand a couple of things, and thank you for that question, Liz. First, you are correct that there are places, including in this country, that are operating schools without a mask requirement at all. I do not support that, especially in a COVID surge, especially because this is one of the layers of mitigation that has been shown to decrease the risk of COVID transmission. In terms of is a KN95 what is absolutely necessary in a school setting? I don't think it is. So what we've been messaging around this is that certainly, and I know this is a little bit in the conversation of this recent schools conversation, that for staff and for students who are feeling more comfortable and wanting to sort of upgrade that mask to a KN95, I want them to have it available. Of course, everybody's in agreement. Having them available for people who are wanting to wear them right now is a good thing. But people have to keep them on. And so I've been really clear that with kids, you know, the most important thing is a mask that fits them and that they can wear. And would I like to be in a world where we didn't have masks at all? Of course I would. That is not where we are right now, particularly here, particularly where there is a lot of worry right now about, about schools. It's the time to be doubling down on all the things that we know make schools, safe, not sources of spread. And so I do not think at all, and I've been very clear about this, it is not a requirement that anybody has put forward that people wear KN95 masks in schools. We think it's important that they are available so that where staff, students, where they are wanting to wear that mask, they're doing it. So thanks for that distinction. Also, Gray Ghost NYC from Twitter just has a really interesting question that in many years of answering questions I have never gotten. So this person is asking, is the Commissioner of Health of the City of Chicago a different position than Commissioner of the Chicago Department of Public Health? And which is your official title? They are the same. Those are both me. My official title is Commissioner of the Chicago Department of Public Health. However, I am also Commissioner of Health for the City of Chicago. So this has to do with the fact that there are different ways these terms are perhaps used across the country. So no, there is not another Commissioner of Health in the city. The way we are organized, formally my title is Commissioner at the Chicago Department of Public Health for the City of Chicago. And then Supermoon Picks from Twitter. I am just going to take this one because I think it's important that I address it. I think you are asking this in jest. I'm not sure. You say, who's paying you to shill vaccines and masks in the absence of discussion about treatments, vaccine side effects, and the value of normalcy? So first of all, I want to be really clear that nobody is paying me at all to promote vaccinations, to promote masks. This continues to be misinformation that is circulated. I would encourage anybody who is interested to take a look at, it's publicly available, what I was paid, and to know that I do not receive any additional funding from anybody. Nobody. I don't have any agreements with pharmaceutical companies. I'm not on a speaking board. I have been really careful to not even have people think that I would have a conflict of interest there. Could I be making a lot more money doing some of these things? Yeah. Would I do it? Absolutely not. Because I think this is what I worry about, that somebody would think that something that had nothing to do with my official position in some way would influence it. So I do not do any of that. And nobody pays me anything different. What I say is entirely independent of that. But also to the larger question, we actually have been discussing a whole lot on here: treatments, vaccine side effects, and the value of normalcy. So if you have a question about one of those, happy to address any of them. Treatments in particular, I'm really excited about because there are real breakthroughs there. And some of the work behind the scenes, like I was saying in the slides that I showed, one of the reasons why we're looking to prioritize testing resources where you can act on them. Like this new testing that we're working to get set up, it's not just can I stand up a testing site, it's can I have a testing site that then connects people to care, especially these newer treatments. So where I've got somebody who's high risk for hospitalization, I want them to be able to get access to a test. That's why the federally qualified health centers, for example, are one of the places where these rapid tests that are so hard to get are being prioritized. And then those same sites, if I see someone there, you do need to get a prescription for these. So you can very quickly get access to the medication. There's IV forms, there's starting to be oral medications that can significantly decrease your risk of serious illness, hospitalization and death if you are infected. And so that's what I'm really pleased about. Vaccine side effects, if you've got a specific question, I'd love you to put that in. We do see short-term side effects. We have a lot of information about that on the website, but we have seen no evidence after almost 10 billion vaccinations around the world of any unusual patterns, anything unexpected in terms of safety, long-term side effects, et cetera. And that is why literally every major medical group endorses vaccination. And the value of normalcy. So what you've heard me talk, I think, a lot about is that what we are working on here is how do we get through this together? Is it normal to have a COVID surge where literally our hospitals are filling up and you're having to wait 18 to 24 hours if you come to an emergency department potentially at some of these folks, unless you are having an absolute life-threatening emergency? That is not normal. That is not good way to be living. Is it normal to have 17 people a day in Chicago on average over the last 7 days dying from COVID-19? Way more than are dying from any of the things that sometimes make the headlines a little bit more. That's not normal. However, where we have seen people get vaccinated and boosted, and you've seen, we show this graph over and over again, it has continued to hold true that the people being hospitalized by and large are the folks who aren't yet vaccinated. And so for people who are vaccinated and boosted, can I promise you're not going to get COVID? I can't. I don't think that is a realistic promise at this point, just with how we've continued to see the virus continue to change, with how transmissible Omicron is. We are going to do everything that we can do to make sure higher risk settings we can bring them down to lower risk, but I can't make them zero risk. And that's even more true with Omicron. What I can do is make sure that we've done the most important things that help protect individuals and help keep people from getting severe disease. That means extra layers of protection around our very highest risk people, prioritizing these medications in case people do get COVID and they have immunocompromised or in long-term cares, making sure they are accessing the treatments, and the testing is also prioritized for those highest risk settings first and foremost. But then at the same time, it is about figuring out what is essential and how do we build layers of safety that do at some level let us live with COVID. Because I think nobody thinks, unless there's some major breakthrough on the treatment side, that we're going to eradicate COVID. That is not a goal at this point. So COVID is going to be with us here. And my team has been thinking a lot about how do we think about it like the other respiratory diseases, flu, RSV, et cetera. These peak, these go down. The interventions could be similar, but we can't live with something that is causing this amount of severe illness and death without having mitigation in place. As our numbers come back down, which I am confident they will do, and we come back down, will we go back to how things were? We will. When we can get back down out of high risk, will we have an indoor mask requirement? I don't expect we will. Will our vaccination requirement for being in high-risk places being in place? Probably not. But if we start to surge, again, in a serious way, especially in a way that threatens our hospitals, this is where, if you're not vaccinated, I'm just really worried about you getting sick and ending up in the hospital. And so that's why we've had to make some of these difficult decisions. So Supermoon, if you've got specific questions about any of those, I'd be happy to address them further. But, in the meantime, let me just be very clear. I push back on a lot of misinformation, but the misinformation that I am somehow being paid or personally benefiting is absolutely not true. And I have to just continue to correct anybody who believes that that is the case. Okay. We are just about at time here. I think, just given all things, we will probably hold on the rest of this. I see people wondering about this for COVID versus with COVID for hospitalizations. I promise we're going to go into a little more detail of that on Thursday, just for time. But let me just super high level let you know that if somebody has COVID and they are in the hospital, they are taking up the same hospital bed. They are requiring the same PPE and infection control and extra care, extra nursing, extra support. And so when somebody is in the hospital with or for COVID, they have the same extra burden. I can tell you that unofficially, when we talk to hospitals, yeah, there are more people, as you would expect in this surge, who are being admitted with an appendix, whatever it might be. You're testing them, and they also have COVID. But that is not the majority. It's they're estimating it maybe 15% that are in that category. Kind of like when people are being, coming into the jail setting, and you're actually testing everybody. You will continue to find people who didn't, who did not primarily know that they have COVID, and when numbers are this high, you'll find some more of that. But that is not what is driving our hospitalization numbers. I wish it were. What is driving our hospitalization numbers, what is driving our, especially people who are, when they're in the ICU, when they're on the ventilator with COVID is their primary reason for admission. Just to be extremely clear about that. You don't continue to have another reason where you would need to have the COVID protocols in place, in indefinite ways in terms of how long, it typically takes someone, if they're not doing well, to move from hospitalization to ICU to ventilator. And unfortunately, some do die. So thank you. If we didn't get to you, we will, we do continue to watch these. Follow us, because we turn some of your questions right into our additional content on social media, and we use it to update our frequently asked questions, because those are different. The questions that I was getting a year ago are really different from the questions that I was getting today. But know that I and my whole team have no goal here and no secondary benefit except to make sure you have the information that you need to protect yourselves, to protect your families, to protect Chicago. And the most important thing, even though this one I've been saying forever, but it hasn't changed, is that thank God those vaccines continue to protect us. Not every single person, but the huge majority of us from serious outcomes, hospitalization and deaths. And as long as that holds, another piece of our goal is making sure that we carefully are learning to go on in the presence of COVID. So we'll be back on Thursday. I am also doing a press conference today at 1 o'clock. That's our regular time. Just me and Dr. Luna from CDPH to show some additional data. Some of you are wondering about this hospitalization. We'll show some more of that at 1. And come back to take more of your questions Thursday at 11. Normal time, normal place. In the meantime, thank you, be well, and be safe.